welcome to Mad Medicine with Miss P. And today, I don't know if I touched on it before. I was trying to remember, kind of looking through my previous little notes here. And I don't know if we discussed it before, but today I want to talk about eyes and nose. So we did everything to prepare for clinical and, even your first job, that sort of thing. We did assessment, NANDAs, care plans, a couple little skills and charting. And I don't know that I got in enough detail with this. I feel like I've done it 1,000 times and I really don't even know if I did it on camera, but eyes and nose are really important. It's important that you understand how to chart them and when to chart them. Once upon a time when we were in the hospital with the students before they came in and changed all the rules, we had the students actually clear all the pumps themselves, and we would write, remember on the paper on the door, before we got super electronic, we would write on the paper on the door all of their eyes and nose, whether they had one bowel movement or how many trips to the bathroom they took, if they didn't have a hat in the toilet. And we would clear the pumps at 2 o'clock every day, so you would know how much IV fluid they got. And it was real simple to do. It sounded tricky, but it really wasn't. You could literally go in there and see what the total was. So we're going to kind of concentrate on that. Let's say for the sake of argument, to make it a little bit easier, instead of going into bathroom trips and that sort of thing, we're just going to talk about eyes and nose by clearing the pump. So at 2 o'clock, we would clear the pump, and let's say that patient had 1,800 milliliters in over the past 24 hours, assuming they cleared every day at 2. They may also do it at night, but let's just say even per shift. Let's say there was 1,800 milliliters in per shift, or 1,100 milliliters in per shift, whatever it was. So if you go look at the output, even if they have a Foley or they have a hat, so you can get a fairly accurate output, and let's say you're missing 500, 600, 700 milliliters of fluid, even 1,000 milliliters of fluid, you may not be able to determine where it is, but what you have to chart is where it's not. So if you are missing that fluid, you need to search for it. You may not find it, but you can at least chart where it's not. So think real common sense wise, starting head to toe, how could we find this fluid? So obviously with a orientation assessment and a mental assessment, you're going to determine, is it surrounding the brain? Are they acting normal? Are they working normal? Are they walking normal? Can they move their hands and feet normally? Can they, is their neuro check normal? That will kind of let you know that it's unlikely to be surrounding their brain and putting pressure on the brain if they're completely normal mentally. Is it 100%? Maybe not entirely, but for the most part, you'll have an idea that it's not in their cerebral cavity to where you're worried about pressure on the brain. It's not accumulating there if they have a completely normal neurocheck. That's one, right? So then you kind of keep working down here and you're going to listen to the lungs, right? Whether you do heart first or lungs first, you're going to listen and make sure that there's no fluid in those areas, right? So when you're listening to the heart, you're making sure that those sounds aren't muffled. If you can hear S1 and S2, but they're kind of muffled and echoey and difficult to really pinpoint, they might have a pericardial effusion. Could that fluid be in the pericardial cavity surrounding that heart and making it more difficult to hear those sounds, in which case we have a big issue. We need to report that immediately, order an ultrasound, let's figure out if it's there, right? Then you're going to listen to the lungs. So if you hear any fluid in the lungs that wasn't there before, your crackles, rails, whatever you want to call it, whether it's at the bases or anywhere else, or if those lung sounds are also diminished and difficult to hear, do they have a pleural effusion? Could there be fluid trapped in the lining around the lungs in the pleural cavity, kind of putting pressure on those lungs to where they can't completely expand, thus diminishing the sounds that the air would make as it moves over the structures in your lungs? So you're like, nope, that's nice and clear. It's not there. I can hear the heart, the lungs clearly. They're awake, alert, and oriented and moving just fine and, passed all their neuro checks fine. Well, then you're going to listen into their abdominal cavity. Is there any distension or fluid movement upon, palpation or auscultation, percussion, that sort of thing? Then you also have to check their bladder, right? You're also going to check, and these are kind of the things we forget first. So I kind of touch on the ones that are not as obvious. So after you're checking for the abdominal cavity and the bladder distension alone, just behind the pelvic bone, and don't be afraid to get it in there. Your bladder is not at your belly button; it is behind your pelvic bone. So you have to kind of dig for it. Those are kind of the things that people don't really think about. So the first three kind of most common places we're going to look for extra fluid is obviously you're going to check the blood pressure, right? That's kind of the first thing we would do. Check the blood pressure and see if it's elevated. Is it in that vascular cavity? Because remember, there are 3 places fluid can hide. So when we talk about third spacing, that is fluid in a space, the areas that should never have fluid, right? So first you're going to check to see if it's in the first space, which is your vasculature, which is where fluid should be all the time, no matter what. That's how you stay alive, to have a blood pressure. So you have to have fluid in that intravascular space. So if their blood pressure is normal, you know it's not there. Well, it could have oozed out to the, let's say, second space, right? And that is in your tissues and between your tissues, intracellular, extracellular, interstitial. That's technically not a space. That's why I've never really understood why they call that third spacing when it's in your tissues, because you should always have fluid, intracellular, extracellular, and interstitial. There should always be fluid around there. That's what you're checking turgor for. Like we talked about in assessment, that fluid should be there all the time. And it's not a space. There are gaps and spaces where lymph fluid lives, but for the most part, that is not a space. That's where fluid should be all the time. So when you're really searching for fluid that you can't find, if they don't have any edema and nothing's obviously edematous or anything to where you could account for 6, 7, 800 milliliters of fluid, then you're going to look in that third space. Those are the spaces that should never have fluid, hence the term third spacing. I know you're going to hear that a lot for edema, or the doctors will say that a lot of times they just chart in their HMPs bilateral lower extremity edema. Like, okay, that's pretty darn vague. So they may or not say third spacing, but in this case, and really in all cases, if you think about it, it's not a space. So when we talk about third spacing, we're talking about fluid being trapped or collected in a space that should not have any fluid at all. Your cerebral cavity, pericardial cavity, pleural cavity, thoracic cavity, abdominal cavity, pelvic cavity, your bladder that shouldn't have excess fluid. You obviously, if it's draining correctly, you shouldn't have a problem there. But those are the areas that you would check for fluid that aren't nearly as obvious as the blood pressure, first space, and tissues, second space. So you want to look for those fluids to make sure they're not where they shouldn't be. So the obvious ones are, you want to immediately check for blood pressure, but a lot of people don't think that immediately. Anytime you're missing fluid in your patient, check the blood pressure, check for fluid in the feet or anything dependent, and then go searching for that fluid. So you may not be able to determine where it is and you can't account for it, but you know where it's not. And that's what you want to chart to protect yourself and your patient. You want a chart that says, listen, I know we're missing 800 milliliters of fluid, but it's not in any spot causing her a problem. So if this patient was just that dehydrated and she has now used that extra fluid we've given her, well, then that's what's happening. Otherwise, look at previous eyes and O's and see if she's continuing to retain it, and then you might have to search harder, let the doctor know, see what you have to do about it, and see if you can hunt it down. So that's pretty much, before we get into disease processes, that's really all I wanted to touch on today is your eyes and O's. Allergies for me is always a pet peeve. I guess we can get into that, seeing as how this is a pretty quick, and we'll probably make this short today. Allergies is always going to be an issue for me. An allergic response is anything that causes a histamine response. So when a patient tells you that it makes me deathly ill, I don't know what that means. Does it make you turn red, itch, or swell? Then I don't care. Then it's not an allergic response. Now, it does mean we're going to give you that medication if it makes you seize, or you have a significant, adverse reaction, like all of the extra primordial effects and all the things that, everybody hates. We're not going to give it to you anyway and say you're not allergic to it, suck it up. But it's really important that you explain to these patients what they are and are not allergic to. And I don't care if it makes you nauseated and vomit and hallucinate, or you get real sleepy, and I can go into days worth of examples of things that patients have told me that they think they're allergic to, and it's literally what those medications do. So it's what they're supposed to do. So that's always going to be an issue. Make sure that you are getting an accurate assessment of a patient's allergies. And if it turns them red, itch, or swell, a lot of times the patient that thinks that they're allergic to 100 different things, this is my favorite, they're like, oh, well, I'm deathly allergic to this, and I can't have this because of this, and I've had gastric bypass, so I can't have any NSAIDs and that sort of thing. And I'm not, and that's a list of my allergies, and there's just a bunch of adverse reactions. And I was okay, have you ever taken, and then they go, after rattling on, I'm like, okay, no, that was all useless information, so I have to narrow it down and say, have you ever taken anything that turned you red, makes you itch, or swell? And she says like, well, yeah, Lortab, but I just take Benadryl with it. I'm like, oh my gosh, okay. That's actually a real allergy. You should stop taking that. I mean, you can probably get away with taking a little Benadryl with it, but your fourth or fifth time of trying to do that, your body may recognize it as a intruder, and then your throat will swell, and then Benadryl is probably not going to help that. So that's an actual allergy. And then I'll have to teach my patient all the other things you rattled on, not an allergy, just miserable side effect, and that happens. That's normal, not an allergy. This whole Lortab thing you're talking about, that's an actual allergy, and there's other medications you can take instead of that. So I would stop taking that and instead ask the doctor for a different pain medication instead of something that you are allergic to. That's a histamine response, right? Runny nose, watery eyes, itchy, hives, swelling. That's a histamine response. Stop taking medications you're allergic to. And then stop giving me lists of things you are not allergic to and you just don't like. God help us all. So that's about it. We're going to get into diseases, I guess, pretty soon, which is it's going to be more involved than I wanted because I'm lazy. Like I always tell y'all, by nature I'm lazy. That's why I'm made for a good instructor, because I want to do less. I want to work less. I want to do less. In which case, when you guys try to make things much bigger than they are, and I'm like, no. Stop writing all of that. Stop doing all of that. Cut it down. You're making mountains from molehills. Just get to the point, cut to the chase, and quit rattling on. I will end this series, if ever we get to the end of the series, with a list of fabulous things nurses, doctors, and patients and students have written down or told me over the years, which will be a lot of fun, I think. So I'm just going to cut this short because I had some running around to do, and I've got 100 other things to do today too. So sorry, I have to limit this because I'm busy. So and my pet peeve today may not necessarily apply to all of you, but for those of you that it does, please comment or thumbs up or shoot me a text or something, because I want to know if anybody else feels this way. When I'm loping circles at a horse show getting ready to run, and you can clearly see the rut I've created by loping circles each way, can you and your friend not slowly walk side by side in the center or on the rail of my ring as I'm trying to continue warming up my horse, or my second horse, or my third horse, or my fourth horse? If you and your friend want to talk and hold hands and just kind of be oblivious to those around you, do it over out in the grass, far, far away, because this is the warm-up pen and you are in the way. How inconsiderate can one person be? Or in this case, 2 people or 3 people. I really like when the 4 of you, the little children, all 4 of them on their ponies, are just blocking everywhere you want to go, and there's no place to warm up your horse because these children who have already ridden their horses for hours and hours on end are now walking in your way. Or my favorite is when they run and cut you off. And fortunately, my horse is broken enough to where when I sit, they sit. But one day, one of these little kids are going to stop dead in front of a horse loping circles that doesn't quite sit like that, and they're going to get pummeled. So parents, watch your children, especially those that can't ride horses to save their life. And adults, be aware of your surroundings. Quit walking in my warm-up pen. If you want to walk far away. Walk on the edges, walk on the grass, or just kind of make bigger circles so those of us that are warming up are not being constantly cut off by you and your oblivious self who already finished warming up your horses. Yes, I get there early, and I know I ride a bunch of horses, and it takes me a while to get them all warmed up, but I'll either go out in the grass, or if I'm in the warm-up pen, just be aware of your surroundings. That's all I ask. I don't think it's too much. All right, so this is a quick one, and I guess next week we'll start disease processes. I don't know. I'm so unprepared. So for the 9 of you still watching, hey, see you next time. And as always, I know I didn't add this in as much as I wanted to, but it's one of my favorite things that my youth pastor said way back when. Forget your fears. Face your fears. Forget your failures. Follow your faith. Love you guys. See you soon.